This is still Learning Plan 9, High Risk Newborn, and this class recording is going to focus on all the other problems that we might see that create a high-risk situation for newborns, other things other than prematurity. So the first thing we have here is post-term infants, those babies that are overdue. We define those as any baby born after 42 weeks gestation, and approximately 12% of all pregnancies you see this situation. If we were to let them go, 12% are going to deliver post-term. And the important issue to think about here is that you start to lose placental function after 40 weeks. It starts to atrophy and shrink and no longer function at total capacity. So you can see a post-maturity syndrome. This infant will be hypoxic and have malnourishment due to that decreased O2 and decreased nutrients. And they might be post-dates, but actually small for gestational age because they've started to lose weight. And they may pass meconium. That's part of that prematurity syndrome, which puts them at risk for aspiration pneumonia. What do these kids look like? They're usually large. They're usually thinner. They actually have loose skin with little sub-Q fat. They'll have little or no lanugo and vernix. Remember lanugo, the fine downy hair over their body, especially over the back area. They will often have lots of hair. Their hair has been growing and growing. And you will see lots of hair, long nails, their skin very wrinkled, and their skin may be cracked and peeling. Basically, they've been in that water far too long, so they come out looking kind of like a shriveled prune. They actually have a higher mortality rate than if they were born at full term. We definitely don't want them born preterm, but they have higher complications and mortality issues than if they were born right at 40 weeks. So the best treatment here is prevention, not let them go to this point. Always assess them for possible birth injuries because they are larger and they might have injuries that occur during the delivery process, but also they have a higher risk for hypoglycemia because they've used up a lot of their sugar stores. So let's talk about small for gestational age infants. These are those infants that are below the 19th percentile. They are small for whatever gestational age they are. They just for some reason failed to grow in utero. We call that intrauterine growth restriction, which is IUGR. They could be preterm infants, full term, or post term. They're just small for whatever their gestational age is. Now, etiology here might be caused by congenital malformations, chromosomal anomalies, fetal infections, poor placental function, might be due to the age of the placenta, or the fact that it's very small placenta, or it started to separate, or had a malformation. Also, maternal illnesses like diabetes or preeclampsia, and smoking, we know, contributes to small for gestational age infants, as well as some drugs and alcohol use. So the treatment here is to prevent it from happening by having this mom being followed with good prenatal routine care. SGA infants are subject to many of those other same complications as we saw in our preterm infants and the post-term infants, specifically the hypoglycemia. So now large for gestational age infants, these kids are big. They're above the 90th percentile. They're usually born to multiparas, not a primep. So somebody who's had more than one baby. Oftentimes the parents are themselves larger. Certain ethnic groups have higher or larger birth weight. They're usually also born to moms with a history of diabetes. These moms have a longer labor. Many times delivery is occurring by vacuum extractor, forceps, or C-section. They may have shoulder dystocia because they're so large they have this difficulty delivering the baby's shoulders. So some of the complications you see are a fractured clavicle. They can have damage to the brachial plexus or facial nerve, hypoglycemia again, polycythemia, cephalohematoma. Congenital heart defects are also more common, and because of all of these things, mortality is also more common. So the treatment here is to identify it during pregnancy so that we can intervene early. Now, meconium aspiration syndrome. This occurs most often in postterm infants who have decreased amniotic fluid or those who are prone to cord compression of some kind, or term infants with intrauterine asphyxia. So what you basically have is some kind of fetal stress that causes that infant to pass meconium in utero, and then guess what? The baby takes it into its airway. And it can cause obstruction of the airways, can cause pneumonitis, and air traps. So here we go, etiology. Hypoxia causes the increased peristalsis of the fetus, and you have relaxation of the anal sphincter before or during birth. And then you get aspiration of that meconium during their gasping movements in utero. And so now you see asphyxia and acidosis when that infant takes its first breath. Meconium, that black, sticky, tarry substance that's in the in the fetal intestines in utero, is like tar. So this meconium will trap air in the infant's alveoli, and that can lead to a pneumothorax because that air cannot be exhaled. It's irritating to the lung tissue, and it causes inflammatory reactions and chemical pneumonitis. And so you might see pulmonary hypertension in these infants. The lungs are also damaged from the growth of bacteria, and so they have a higher incidence of infection all the way around. You can imagine that black sticky tar is not going to allow for a lot of movement of air inside the infant's lungs. So what do you see? You see tachypnea, cyanosis, retractions, nasal flaring, grunting, rales, rhonchi, all those normal things we see with respiratory distress. And the other thing you see that's a little different is a barrel-shaped chest. And when you do an x-ray, it confirms atelectasis, consolidation of the meconium, and hyperexpansion of the lungs. So it's diagnosed in this way. Now, management. If we see this during labor, if we see that baby has passed meconium, we have green amniotic fluid, we can do an amnio infusion where we infuse some saline, normal saline, into the amniotic fluid, and that will dilute that thick meconium. So we have thinner meconium, and it's easier managed by that infant. At birth, once the head is delivered, but not the body, we can suction their oral pharynx before delivery. We can actually insert an ET tube and use that to do deep suctioning because that meconium is going to totally stick inside a small catheter and obstruct it. And if they need oxygen, we might want to humidify that oxygen and they also might need mechanical ventilation. So another complication with a high-risk situation is sepsis. The definition here is where you have a systemic infection from some bacteria that's in their bloodstream. So infants don't just get like a tiny little infected hangnail. They're going to get an entire systemic body infection. It goes throughout their body, and we generally will do a septic workup by looking for bacteria in the blood. So they'll do blood cultures. In the urine, they'll get a urine sample and culture that, and spinal fluid culture. So we're looking everywhere. Remember, our newborns are especially susceptible to infection because they have an immature immune system and they react more slowly to invasion by organisms. But in the preterm infant, you have an even more immature immune system. What are our more likely agents of sepsis? Well, Staphylococcus, E. coli, Group B strep, Haemophilus influenza, and Listeria. And probably the most common of all of these and the most serious is the Group B strep. So all these different signs of sepsis are going to occur in that newborn. You are going to, one of the first things, see temperature instability, respiratory distress, but also changes in their color. They might be cyanotic or very pale or have mottling of their skin. Mottling is where you actually see a almost a roadmap appearance of the baby's skin, kind of a lacy appearance under the skin. Tachycardia and hypotension are there. Decreased peripheral perfusion, so you see a lot more acrocyanosis. Poor feeding, vomiting, decreased muscle tone, and they can either be very lethargic or they can be very irritable. So how do we treat it? Well, early identification is essential to prevent this baby from dying. I have seen a baby die within 3 hours of delivery from a Group B strep sepsis. So it's nothing to fool around with. We need to know what are we looking for and how do we identify it early. Maybe we don't wait for cultures to come back. We get the cultures, but then we go ahead and we start them on antibiotic therapy. And then supportive care. They probably need some oxygen, some extra heat, some extra glucose. Prevent the spread of infection and support the parents, because remember, these parents are sitting there going through all the signs and steps of the death and dying process. Elizabeth Kubler-Ross. Not saying that this infant's going to die, but the parents are scared to death that there's the risk of this infant dying. And so they're going to go through all those stages. And how can we support them? How can we provide them with information, allow them the time to spend with the baby, and yet protect the baby and keep the baby safe? Hyperbilirubinemia is another complication. Remember, we talked about the normal physiologic jaundice that occurs in infants. It occurs after 24 hours, and it builds up gradually, and it's from that breakdown, that normal process of breakdown of red blood cells. Well, here we're talking about something beyond that. We're talking about the pathologic jaundice. When jaundice first starts to appear early, in the first 24 to 36 hours, when you measure their bilirubin levels, they're increased. And this can lead to a condition called kernicterus. It's when you have an abnormal accumulation of bilirubin in the CNS tissue. It actually leads to staining, yellow stain of the brain, which can cause what's called bilirubin encephalopathy. It has high mortality rates. But if that infant does survive, they usually have long-lasting mental problems, developmental delays, that sort of thing, hearing loss. cerebral palsy, or long-term neurologic and developmental problems. Now, the cause here is not a normal physiologic process. It's any condition that causes additional destruction of the red blood cells. And the most common problem is the hemolytic disease, which is your Rh blood incompatibility. But it could also be an ABO incompatibility, where mom is type O and the baby is either A, B, or AB, and the mother's body has started that breakdown process of the baby's red blood cells, has attacked the baby's red blood cells, and you have a positive Coombs test in that situation. So how do we treat it? Well, we need to prevent kernicterus by looking at the history, taking all those diagnostic tests that we need to assess for infection or blood abnormalities, provide them with optimal nutrition. They need frequent feedings because that will prevent the hypoglycemia. We need to give them adequate protein to maintain their albumin levels, promote GI motility, and prompt emptying of bilirubin from the bowel. So if babies are eating well, especially protein, bilirubin will bind to protein and help them to get rid of it. But they may need phototherapy. Some of these babies do need the special blue lights of phototherapy to help their liver to change that bilirubin into something that they can excrete. If all else does not work, these babies might need what's called an exchange transfusion, where you actually remove the sensitized blood and replace it with type O negative blood. Now, this is seldom done and seldom needed, but when phototherapy does not work, this is our last ditch effort. And so we're going to take out as much as 3 times that baby's total blood volume to make sure we get all the sensitized blood out. The sensitized blood is the blood that is high bilirubin levels. Now, let's talk about infants of diabetic moms. These babies might be SGA, small for gestational age, due to the decreased placental blood flow, and that is causing that IUGR. But more commonly, you'll see macrosomic babies, very large. In 33% of moms who are diabetic, even when they have good control of their blood sugar. And that's because of the response of the insulin, and then the insulin being a fat storing hormone. We talked about that a little bit in our high risk perinatal situation. So what you've got going on here is large glucose molecules from mom cross the placenta to the baby, and the insulin from mom does not cross the placenta. So the infant increases its insulin production to control the blood sugar, and that leads to hypertrophy of the islet cells in the pancreas. And remember, insulin is a growth hormone, so it's laying down stores of fat. Now this baby's going to be at risk for hypoglycemia because the infant's pancreas is used to secreting large amounts of insulin because mom's insulin does not cross the placenta. And so now the baby's born, but it doesn't have the benefit of mom and her high glucose level. You just have the baby all on its own, used to producing all this insulin, so their blood sugar drops. So what do we see? We can see hypertrophy of the baby's liver, adrenal glands, and the heart. They usually have a length and head size that's generally within normal limits for their gestational age, but they'll have a very round face and obese body. Their skin is very red in color. They have a very poor muscle tone at rest, and they might have tremors with stimulation. Other risk factors. They're at risk for trauma during delivery. They have a risk for fractures, especially the clavicle fractures. They have a risk for cephalohematoma and brachial plexus injuries, shoulder dystocia, cephalopelvic disproportion, because they're so large. They're having trouble getting through that birth canal. They're at risk for asphyxia and respiratory distress syndrome. Those high levels of insulin interfere with the production of surfactant. They also can have hypocalcemia and hypomagnesemia. They'll have polycythemia due to hypoxia and hyperbilirubinemia due to that breakdown of RBCs after delivery. So we need to do some nursing interventions here. Our therapeutic management. Let's control mom's blood sugar during pregnancy. Try to keep it as stable as possible. No peaks and valleys, because that will decrease the complications. Feed this baby early, as soon after delivery as we can, and that baby is stable. If the baby's hypoglycemic, it's best for them to feed with breast milk, and you can give even very small amounts of 10% glucose, followed by breast milk or formula. If need be, we can gavage, in other words, feed tube feedings for this infant if they're not sucking well or they have a respiratory rate greater than 60. Now remember, anytime they're tachypnic, greater than 60, that baby has lost its ability to suck and swallow and breathe at the same time. So they're going to need an IV, and we might need to give them glucose through the IV. And if we give them too high levels of glucose, you can see a rebound of their hypoglycemia. So instead of giving them D50, we'd rather give lower levels of glucose to try to stabilize their glucose levels. Prenatal drug exposure makes this baby at a greater risk for high-risk situations. We call this neonatal abstinence syndrome. This occurs when the infant has suffered prenatal opiate exposure that is now significant enough to cause withdrawal signs after birth. There's a special evaluation tool called the Neonatal Abstinence Scoring Guide, and it's the Schlitz, that's a tough one to say, scoring guide, and this helps us to identify signs and symptoms in the infant that show signs of withdrawal. So what we might see is the irritability. They have hyperactive muscle tone and a very, very high-pitched cry, this high squealing cry. Tremors might be present, but they can have normal breath sounds. They appear hungry. They're sucking vigorously on their fists, but yet when you actually try to get them to suck on the breast or a nipple, they have very poor suck-swallow coordination, very disorganized suck. They'll frequently regurgitate, vomit, and have lots of diarrhea. And so therefore with that diarrhea, you see red excoriated buttocks. They have a failure to gain weight, and they're very hard to console, and they don't sleep well. So normally babies that are uncomfortable, you can pick them up and cuddle them and hold them and rock them, and they are comforted and they quiet down. Not these babies. They do not want to be touched, and it's very, very difficult to get them to quiet down, to be comfortable, to be consoled. So how do we manage them? Well, drug therapy might be indicated in 50 to 60% of the time. We can use things like tincture of opium, phenobarbital, oral morphine, or diazepam. But we have to be careful because these medications can have side effects also. so we need to taper their medication dose. Sometimes we actually use methadone with these babies. Our nursing management, let's start with feedings. We're probably going to have to use gavage feedings, in other words, tube feedings, if they have a poor suck or if they're at risk for aspiration. And they might need an increase in their calories because of their tremors and their irritability. They're using up so many of their calories. They need lots of rest. Keep their stimulation to a minimum. Reduce the noise and the bright lights. Have a very calm approach. Not a clam approach, a calm approach with slow movements, and swaddling helps to comfort them. We need to focus on this bonding between mom, baby, dad, baby, that parent-infant interaction. Mother might need other treatment, so assess for that mom-infant interaction and allow mom to assist with the care involved with the infant. And we most likely will need a social services referral or public health referral or both for follow-up outside of the hospital. Fetal alcohol syndrome, we talked about that just slightly in the high-risk perinatal situation. Just remember the fetus cannot remove the breakdown products of alcohol, so you get a large buildup of this, and that leads to a vitamin B6 deficiency, and without vitamin B6, you have neurologic damage. So look at all the signs and symptoms you can see with fetal alcohol. And the most serious long-term effect is going to be that cognitive impairment. Remember the craniofacial deformities that you see, the upturned nose, the thin upper lip, that short palpebral fissure between the lip, and then the wide-set eyes, low-set ears, and each child has more pronounced craniofacial deformity and more pronounced cognitive impairment. We can also see chromosomal abnormalities. The most common ones are trisomy 21, which is Down syndrome, and trisomy 18. And these create a high-risk situation for infants with a lot of other issues involved with them. Trisomy 18, many of these kids have a very, very short lifespan. So we would deal with each of these and all of their issues surrounding them. And this will end the class recording on Learning Plan 9, which is focusing this part on the other complications with the high-risk newborn.